Hello, my dear students. This is Dr. Rohit Daniel, your orthopedics faculty from Doc Tutorials. Today, we are going to discuss about splints that we use in orthopedics. What are these splints? Splints, you see, are any device that we use for temporarily immobilizing a fractured or dislocated limb. Okay, so whenever there is a fracture or a dislocation, obviously the patient is going to be in severe pain. And again, if you are not immobilizing that injured limb, there is going to be aggravation of injury, isn't it? And for these two purposes, we use splints. Any temporary device that we use for immobilizing a limb in the case of an injury is called splints. So remember, whenever a patient comes to you with an injury, remember, before sending for an X-ray, always apply a splint. This will help in alleviating the pain for the patient, and secondly, it will also prevent the abnormal mobility at the fracture ends, or in the case of a dislocation, it will prevent the abnormal mobility at that site and prevent aggravation of injury. If you don't do that, it's possible that the fracture ends can impinge on the adjacent nerves or vessels and cause injuries. So we'll be discussing the various important splints that we use for orthopedic purposes in this session. Alright then, let's discuss the important splints and other devices that we use for the upper limb injuries in orthopedics. So let's start with what we call a C&C sling or cuff and collar sling. What is that? It is one of the easiest devices that you can use for immobilizing temporarily an injured upper limb. It can use this for various kinds of injuries such as shoulder dislocations, other shoulder injuries, fractures of the humerus, elbow dislocations, and even injuries of the forearm and wrist. The only thing you need here is a roll of cotton bandage. Something like this. So what we do is that you take a sufficiently long length of cotton bandage like this, and you make sure the patient is seated comfortably, and you put it around the neck like this. And once you have enough length, you can cut it off at this point. And next is important steps. The way you put knots. There are two knots you have to make. First knot should be under the neck like this. In this area, it has to be a double knot so that it is secure and does not slip. Now, whenever you put a knot like this, remember that the chin should be cleared like this. Why is this important? If the patient wants to take a bath, he can take this out without cutting the C&C sling. That is the point you have to remember. Then once you do that, next you can ask the patient to flex the elbow like this. Then you put a knot around the forearm like this and you secure it. Make sure that the elbow is flexed to 90 degrees. Now whatever excess bandage you have, you can cut it off. Make sure the patient is comfortable and look at the position of the knot here. I have purposefully put the knot here and not at the base like this. What will happen if you put the knot here? The knot will dig into the patient's skin and it will be very uncomfortable to the patient. So make sure you put the knot either in front or back. So this is your simple cuff and collar sling. You can use this for any injury of the upper limb, and every doctor should be able to do this on his or her own. Now this is how you put a cuff and collar sling, and it is important that all the doctors should be able to apply the simple immobilization technique for any upper limb injuries. Next splint that we are going to discuss is a simple arm pouch. I am sure that all of you would have seen this before. This is a very simple device which you can use for immobilizing an injured upper limb. Any injuries of the shoulder, humerus, elbow or forearm, and even wrist, you can temporarily immobilize with an arm pouch. Okay, so let's see how you apply an arm pouch. This is a very simple device. What you have to do is that you open the arm pouch like this, ask the patient to slip the forearm inside like this. Make sure the elbow of the patient comes in contact with the corner of the pouch like this. Then only the splint will fit well. Once you do that, you take the strap that you see here around the neck like this. Then you can wind it around like this and you can fix it on the top. So that's it. This is a very simple device. It will be available in all the hospitals. For other upper limb injuries, you can use this. Next splint we are going to discuss is this. What splint is this? This is the splint that is often asked for your exams, isn't it? This is your cock cup splint. Which condition do you use the cock cup splint? It is used for wrist drop. What is wrist drop? Wrist drop is the position like this, isn't it? Where the patient cannot dorsiflex the wrist. And which condition produces this? It is seen in radial nerve injuries. And the treatment for radial nerve injuries causing wrist drop is to give a cock cup splint like this. So imagine a patient with wrist drop like this. What you do is that you can apply this splint. It is very easy to apply. So you have these straps which you can open up like this. Then you place it in the volar aspect of the patient's forearm like this. So you can see that once you apply this, the wrist is by itself going into dorsiflexion because of the support of the splint. So this is how you apply a cock cup splint. So remember, cock cup splint is a very important spotter for your exams, and it is used in wrist drop, which is seen in radial nerve injuries. Now let's look at the next important splint that we use for a nerve injury again. So which condition is this? This is obviously your claw hand, isn't it? Which is seen in association with an ulnar nerve injury, where you have this hyperextension at the metacarpophalangeal joint and flexion at the IP joint. And for correcting this deformity, we use this splint. This is what we call as the knuckle bender splint. So what this does is that you can apply the knuckle bender splint like this. So once you do this, you can see that the knuckles are in flexion now. The knuckles are now in flexion. Now we can even ask the patient to flex and extend the fingers. So this is your knuckle bender splint. So here I am applying the knuckle bender splint. So whenever I am applying the knuckle bender splint, I am putting it as far inside as possible, and you can see that now the knuckles are in flexion. Knuckles is nothing but your metacarpophalangeal joints which are in flexion, which used to be in extension in flexion, and once the MCP joints are flexed, you will see that the patient can even extend the fingers in the IP joints. So this is the function of your knuckle bender splint. Now can you identify this brace? This is a very simple brace which we use for conditions like tennis elbow and golfer's elbow. Do you know what it's called? It is called the counter force brace. Counter force brace. I know this is popularly called as the tennis elbow brace or the golfer's elbow brace, but the scientific correct actual name is counter force brace. Now how do you apply this brace? This is very interesting. You know, in tennis elbow, where is the problem? Tennis elbow is nothing but lateral epicondylitis, where there is inflammation of the lateral epicondyle, isn't it? So you might obviously think that you have to put the brace on top of the lateral epicondyle, but that is not the way. That is not the way you have to do it. So if this is your lateral epicondyle, you have to apply the brace a little bit below it, probably 2 finger breadths below it. So instead of putting it right over the lateral epicondyle, we apply it just below it like this, and make sure the patient puts the brace snugly and tightly like this. Okay, so this is how you apply the counter force brace or the tennis elbow brace. Now what is the idea behind putting the brace like this? See, the primary problem in tennis elbow is an overactivity of wrist extension, and this will cause the inflammation of the common wrist extensor origins. So the idea here is that whenever the patient is doing his daily activities, this counter force brace will prevent the transmission of the effort till the lateral epicondyle. So basically this device offloads the lateral epicondyle, causing pain relief. And it is not the lateral epicondyle where you have to apply it. You have to apply it 2 finger breadths below it, somewhere here. That is the right way of putting the tennis elbow brace or the counter force brace. Remember, counter force brace is also a very important MCQ which has been previously asked. Let's look at the next splint. Can you tell me what splint is this? This is the thumb spica splint. What is that? Thumb spica splint is used for temporarily immobilizing your thumb. You can use it for minor thumb injuries, but primarily it is used for a condition called decurvent stenosynovitis. What is that? It is a condition where there is inflammation of the first dorsal compartment tendons, which are your abductor pollicis longus and extensor pollicis brevis. And in order for relieving the symptoms of these tendons, you can apply the thumb spica splint. Now let's see how we apply the thumb spica splint. So remember, thumb spica has a long part and this fabric material that comes at the bottom. So remember, this longish part should come on the radial aspect of the thumb. So we apply the splint like this, and you secure the thumb first, and then you wrap this part around the wrist and securely fix the velcro strap. So this is how you apply the thumb spica splint. The longish part should be on the radial aspect of the thumb, and you secure the thumb with the velcro straps first, then you wrap this part around the wrist and secure it around the wrist. How this will appear in the end. So you can see the longish part should come on the radial aspect of the thumb. Now this splint that you see here is your wrist immobilizer. Wrist immobilizer, which is used to immobilize the wrist. You can use it for minor wrist injuries, and it can be also used for an important condition called carpal tunnel syndrome. What is carpal tunnel syndrome? It is a condition where there is a blockage or compression of the median nerve at the carpal tunnel, and because of this, many patients will have severe paresthesias of the upper limb, especially during nights. Patient may not be able to sleep at night because of the severe paresthesia. So what you can do is that you can ask the patient to put this brace at night, and this will relieve the pressure symptoms on the of carpal tunnel syndrome, and the patient will have a good night's sleep. So this can be used in carpal tunnel syndrome. How do you apply this? This is a very simple device. So you ask the patient to keep the hand out like this, and you slip it inside. Slip the wrist immobilizer inside like this, and ask the patient to take the thumb out this way. Now you have all the straps here which you can readily apply. So this is your wrist immobilizer. Now what brace is this? This is the clavicle brace, which is also called as figure of 8 brace, which is used in which condition? Fractures of the clavicle, isn't it? So imagine that my friend here has a clavicle fracture. So how do you apply this clavicle brace? You ask the patient to turn around. Then you ask the patient to keep the arms on the hip like this. Now this part goes posteriorly like this. Then you take these two straps, wind it around the shoulder and the axilla like this. You have places to put this inside like this, and you have a spike lock here which can be used to lock it in place. So you can use the same method on the opposite side as well. Make sure that it is as tight as possible. If it is loose, it is not very useful. Make sure it is as tight as possible. So if you feel that one side is loose, you can always correct it and make it tight once more. And you should also make sure that the patient tightens the brace every day, so that whenever the patient is sleeping, obviously there is a chance that the brace can become loose, and every day the patient should make sure that it is tight. You should teach the patient to tighten the brace. Now this is how the figure of 8 brace will look from the front, and many a time this is the picture that you will get for your exam. Because this has been asked as a spotter previously. Now what splint is this? This is your foot drop splint, isn't it? Which is used in which condition? Obviously foot drop. Foot drop is what? The inability to dorsiflex the ankle, which is seen in common peroneal nerve injuries. So CPN injuries, you often get your foot drop, and the characteristic gait in a foot drop patient is what? High stepping gait. So in this condition we use the foot drop splint. So you can see that this patient has a foot drop here. He is unable to dorsiflex. So what we will do is that we give this supportive splint for the same. So this is a very simple splint. You keep the foot inside, like this, so that the foot will become dorsiflex and you can just tighten the straps. This is the foot drop splint. Now, can you tell me what splint is this? What is this? This is the bunion splint. What is bunion splint? It is used for a condition called hallux valgus. What is hallux valgus? It is a condition where the great toe is deviated outwards at the metacarpophalangeal joint. So what will happen is that because of the hallux valgus deformity, the head of the first metatarsal will form a small bulge, and this is what we call as a bunion. And sometimes bunion can be very painful and it will cause difficulty for the patient to walk with this deformity. In this condition, we use the bunion splint. So I'll show you how to put this bunion splint. Before that, you must understand the various parts of the bunion splint. So if you see the bunion splint, you will see that there is this plastic elongated area which should come on the medial aspect of the foot, and on the inside there is a cup like depression, and this cup like depression should correspond to your
metatarsophalangeal joint
or the bunion. Understood? So now I will show you how to put the bunion splint on the foot. What you do is that you slide the splint like this. Make sure that the plastic elongated area is on the medial aspect of the foot like this, and this depression on the splint should rest on the bunion. Once you do that, you put this around the big toe and tighten it. All of these are Velcro straps. You can tighten it or loosen it as much as you want. Then you tighten the strap around the foot as well. So the advantage of bunion splint is that it will keep the deformity in a corrected fashion. Second, there is a hinge here. Because of the help of the hinge, the patient will be able to flex and extend the great toe without any difficulty. So walking will not be a problem. Flexion and extension of the big toe will be possible. Only problem is that the patient will have to wear this throughout the day while he is walking. Now what device is this? This is actually a knee immobilizer. There are two kinds of knee immobilizers. One is a long type and a short type. This is a short type knee immobilizer which can be used for minor injuries of the knee, especially if there is an injury to the knee and there is some mild effusion inside the knee. You have to immobilize the knee for a few days. For this, you can use a knee immobilizer. How do you apply this? Again, this is a very easy method. See, on the posterior aspect of the splint, you have two metal rods which are designed to prevent the knee from flexing. And on the anterior aspect, there are two flaps to go around the knee. So you can just ask the patient to lift the leg and you keep the splint behind the knee and make sure that the patella is here. All the knee immobilizers will have this kind of a opening in the front, and that opening should correspond to the patella. That is the important point. It should not go below, it should not go proximally. The patella should correspond to this opening. Once that is achieved, then the rest is easy. You can just strap the device on like this. These are all Velcro straps which you can just easily apply. Now this is how you apply a knee immobilizer. Now can you tell me what brace is this? This has been a spotter asked for your exam before. What is this? This is the Taylor's brace. Taylor's brace, which is used for what? It is used for minor fractures of the vertebrae, especially minor wedge compression fractures which are seen in osteoporosis. It is very often seen that elderly women or aged men can fall and they can have small fractures of their vertebra, which usually is a small wedge compression fracture which is stable and which is not associated with any neurological deficit. For those kinds of patients, you can very well use a Taylor's brace for treatment. So how do you put the Taylor's brace? You can see that it is a very long brace and there are two large metal rods at the posterior aspect which gives adequate support to the entire spinal column. So how do you put this? You ask the patient to turn around like this. You stand on the back of the patient and you place this part posteriorly like this. And this metal rod is actually pre-bent. So it will correspond to the normal lordosis and kyphotic curvatures of the spine. So it is quite easy for you. Once you do that, you strap the abdominal straps to the front like this. Now you can see that I have strapped the abdominal straps to the front. Next step is what is important. You have two straps like this that go around the shoulders. So you have to wind it around the shoulder like this. Take it behind. Can you turn? And you have a device like this. You have to put it through it and stick it on the side. Same on the other side. You hook it inside this. Then you tighten it and you stick it on the side. So you can see this is how you apply the tailor's brace. This is from the back and this is from the front. This is your tailor's brace. Now can you tell me what brace is this? This looks like a cross and it goes in the front of the body like this. It might look like some kind of a chest brace or a rib belt, but it's not the case. It is actually a type of a spine brace, which is called the anterior spinal hyperextension brace or ASH brace, ASH, anterior spinal hyperextension brace. So what is the use of this brace? Again, this is used for minor fractures of the vertebra, where it is important that the patient does not stoop forward or bend forward, because if the patient tries and bend forwards, then there is a chance that the fracture can collapse and become unstable. So in order to prevent that, you are putting this brace anteriorly. So remember, this is a spine brace even though it is applied anteriorly like this, in order to prevent forward flexion of the spine. Understood? So this brace will have an anterior part like that, which is more important, and it also has a posterior piece like this. So it is very easy to apply. You can ask the patient to apply it like this. You just ask the patient to hold on to the brace for some time. Then you ask the patient to turn around. Then you can keep the posterior splint like this, and there are straps available in the front which you can apply. Make sure you tighten it on both sides like this. So this is the view from front. You can see the anterior spinal hyperextension brace. You can see that the patient is not able to bend forwards. Why? Because of this restriction in the front. And this is what you see from behind. So this is your anterior spinal hyperextension brace or ASH brace. Can you turn forwards? So now we are going to discuss three of the most important splints that we have to know in orthopedics. These three splints can be life-saving for the patient. Which are these three splints? First is your cervical collar, Philadelphia collar. Second is your pelvic immobilizer, and third is your Thomas splint, which we use for fracture shaft of femur. These three devices are very, very important in your emergency department, because if you apply these splints correctly in the right time, you can save the life of the patient. So we will first take a look at the Philadelphia collar. So what is this Philadelphia collar? It is a rigid cervical brace which we use for preventing the mobility of the cervical spine. For any patient who you are suspecting a cervical spine injury, you must apply the Philadelphia collar before you send the patient for an X-ray. This is very, very important. Second important point you must remember is that if the patient is unconscious, then you must presume that the patient has an associated cervical spine injury. Then only you send the patient for a CT or an X-ray. Many a time what happens is that when the patient comes in with a head injury, you are too focused on the head injury and you will completely forget about cervical spine injury. So what happens is that you shift the patient for CT, and by the time the patient goes to CT and comes back, the cervical spine the injury has already worsened, and probably the patient is going to end up in quadriplegia. We do not want that to happen. So remember, any unconscious patient, You presume that the patient has an associated cervical spine injury and you treat him accordingly by putting a Philadelphia collar. Understood? So Philadelphia collar, remember, has two parts. An anterior part with a hollow in the front like this. And what is the use of this hollow or a hole? This is for tracheostomy. If you want to do a tracheostomy for the patient, you can do it without removing the Philadelphia collar. That is the advantage of Philadelphia collar. And then you have the posterior part like this. Now the question is, why do you want these two parts? See, if you only use a single collar with a single piece, the problem is that you may have to manipulate the neck too much to apply this. But in the case of Philadelphia collar, because it comes in two separate parts, you don't have to manipulate the neck too much. You can easily slide the collar in and put it. I'll demonstrate to you how to put it now. See, whenever you are putting a Philadelphia collar, you need an assistant with you who is going to stabilize the head and neck for you while you are putting the Philadelphia collar. Okay. So, first thing that we do is to apply the back part. So, you always look for the directions that is given here, which is up and which is low. So, first thing I do is that I'll flatten the collar like this. You ask the assistant to hold the head and gently lift the head up, stabilizing the neck. Now you slide the cervical collar underneath like this. Then you ask the assistant to leave the head. Now you can see that the cervical collar is almost in place. Then you can gently slide it in like this. So you don't have to manipulate the neck too much and the posterior part is already in. Once you do that, you can apply the anterior part like this. This will go all around the neck. And you have Velcro straps on either side which can be used for stabilizing the anterior part like this. So this is how you apply the Philadelphia collar. Remember, you have the hole in front for applying a tracheostomy if the need may be. Next, let's look at the pelvic binder. What is pelvic binder? It is a device that we use for compressing the pelvis whenever there is a patient with pelvic fractures. Now, what is the problem with pelvic fractures? Pelvic fractures are notorious for causing hypovolemic shock and even death. And why does this happen? This happens because when the pelvis breaks, it will open up like a book. That is what usually happens. This is what we call as an open book fracture. When that happens, all the pelvic venous plexus on the inner side of the pelvis will get torn and it will start bleeding. And the only way in which you can stop that bleeding is to compress the pelvis. And in order to compress the pelvis, we use this device called a pelvic binder. So how do you apply this pelvic binder? It is quite easy, but you need an assistant for this. Usually the patient would be unconscious or will be drowsy because of hypovolemia. And what you will do is that you ask the assistant to hold the pelvis like this and gently lift up the pelvis. And when the assistant is lifting the pelvis up, we put the pelvic binder around the pelvis. And once you do that, you tighten the straps in the pelvic binder. You have to tighten it as hard as possible. This is how you apply the pelvic binder. Now you can see that the pelvis is nicely compressed. So this will compress the opened up pelvis and this will cause the tamponade of the pelvic venous plexuses and this will stop the bleeding. So remember, this is one of the first steps that you have to do whenever you get a patient with a pelvic fracture. Now, can you tell me what device is this? This is a very important spotter for your exam, right? So what is this? This is the Thomas splint. Thomas splint is one of the greatest splints that has ever been designed. This was invented by Dr. H.O. Thomas in 1850s. He is actually known as the father of British orthopedics. The first use of the splint was to treat tuberculosis of the knee joint. But later, people found that this is very good device for immobilizing the femur fractures. And the use of this mainly came during the First World War. See, in First World War, many soldiers were dying because of fracture shaft of femur, and they were not dying at the site of injury, but they were mainly dying once they were transported probably for several hours and they reached the military hospital. By that time they would have been died. Why? Because of the various complications, because of not properly immobilizing the fractured femur. But once they started using Thomas splint, the death rates had remarkably improved. See, before the use of Thomas splint, the survival rate for a patient with fractured shaft of femur was around 20%. But after we started using Thomas splint, the survival rate increased to 80%. 4 times improvement in survival. That is the greatness of Thomas splint, and Thomas splint has saved millions of lives during the last 1.5 centuries. Now, what are the parts of the Thomas splint? If you see, you can see that there is a ring in the uppermost part and there are 2 rods on either side which is connected at the bottom. You can see that both the rods are tapering towards the bottom. And if you notice carefully, you will see that one end is shorter than the other side, isn't it? And this shorter rod should go on to the medial aspect of the leg. Now I will show you how to put the Thomas splint. Again, for the application of Thomas splint, you need an assistant who will give a traction to the limb and stabilize the limb. So I will gently put the Thomas splint inside like this. My assistant will give traction and hold like this, and make sure that the ring should hitch against the groin of the patient like this. And once that is done, you can apply bandages to secure the limb. Make sure that the limb is in traction, and apply the bandage in such a way that external rotation of the foot is prevented like this. If you wind it around the foot like this, then it will prevent the external rotation of the foot. So make sure you nicely put bandages all around the leg and the femur to stabilize the femur. So this is how you apply the Thomas splint. And there are 2 important advantages of using the Thomas splint. One is that obviously it will prevent hypovolemic shock in the patient because it will stabilize the fracture of the femur, and this will prevent large amounts of blood being lost. Second is that it will also prevent a serious complication of fracture shaft of femur, which is fat embolism. And for these 2 purposes, you will have to apply a Thomas splint before sending the patient to take an X-ray. Now let's discuss how can we apply plaster of Paris in a patient with an injury to a limb. So plaster of Paris slabs and casts are the primary modality of treatment in most of the injuries in orthopedics. And as far as an UG or an house surgeon is concerned, the primary role for you is to learn how to put a slab. Putting a cast usually comes either in the postgraduate training session, and obviously you will have to do it once you train out and you start your own practice. But as an intern or as someone who has just passed out of MBBS, your primary duty is to understand how to apply a slab. What is the difference between slab and a cast? See, slab is a device that we use to immobilize the limb in the setting of an edema, in the setting of an acute injury. Here, the advantage is that only one circumference of the limb is immobilized. So, one circumference or half the circumference is opened. So, the advantage here is that even if there is swelling because of the acute injury, there will not be any constriction effect and there is no risk of vascular damage to the limb. So if you put a cast in an acute setting, there is a risk that after a few hours, it can increase the edema after some time and it can cause compartment syndrome and other such complications. So always in the setting of an acute injury, apply a plaster of Paris slab. Now these are the things that you require for putting a slab. So for demonstration purposes, I am putting a below knee slab or a BK slab. First thing that you need is obviously plaster of Paris. Plaster of Paris now comes in rolls like this. You can use a 15 centimeter roll. Usually for below knee slabs, you need 2 such rolls. Then you need a pair of gloves. Then you need something known as a stockinette. Then you need a bandage roll. Then you need soft roll cotton like this. And obviously you will also need some water for immersing the POP. So first thing you do is obviously to apply the gloves. Next thing to do is to measure the length of the POP that we need to make the slab. So generally for below knee slab, we measure from the ball of the big toe till around 3 finger breadths below the popliteal fossa. Then you can ask the patient to lift the leg a little bit. Then you can measure out the POP like this. Once you do that, next step is to make a slab by layering the POP one layer at a time on top of each other. So generally for below knee slabs, we need 2 POPs like this. So this is our below knee slab ready. Now we'll see how we can apply it on the leg. Next, you can ask your assistant to hold the limb like this. Now this is your stockinette, which is a sock-like thing that you can put it on top of the leg. This will protect the skin of the patient. Make sure that your stockinette is cut a little bit longer than your POP. Why that is important, I will show you in a bit. So you have done that. Next layer is to apply cotton. This is what we call as a soft roll cotton, which is readily available. You start rolling the cotton around the leg like this. From the foot, you have to go proximally. Make sure that you give adequate padding around the angle, especially around the bony prominence. Your malleoli and all should be well padded. Otherwise, what will happen is that there will be ulcer formation around the bony prominences. So now you have applied your soft roll cotton. Next step is dunking your POP slab that you have already prepared into water. So you dunk it fully inside water and wait for around 10 to 15 seconds till the whole slab gets soaked with water. Then you take it out and squeeze out the excess water like this. Then you straighten your slab with your fingers, make it into the beautiful rectangle shape that you need. Once you do that, you apply the POP slab like this posteriorly. Make sure it starts at the ball of the big toe and you gently just massage it slowly so that it becomes in the shape of the leg slowly. Once you do that, you take a bandage and securely tie it around the leg like this so that the POP slab gets fixed onto the leg. Make sure that when you are doing this, the angle of the patient should be in dorsiflexion. You do not want the leg to be in equinus, because if there is equinus, there is a risk of Achilles tendon contracture. So once you have wrapped 1 or 2 layers around the leg with the bandage, you can cut the bandage. And next step is what is important. You can roll the edges of the stockinette like this, which will give a very nice finish to your slab. That is why I told you earlier, you have to take the stockinette little bit longer than the size of the slab. And once you do that, you can again use your bandage to roll around the leg and fix the slab. Once you feel that the bandage is sufficiently tight, you can just stop and tie it off. So that's it. That's your below knee slab. You make sure that all the toes are outside and it is well mobile.